Welcome back to MedNexus for another explainer. Today, we're tackling an absolute classic, a fascinating monogenic autoimmune disease that is a true MedNexus essential. It's a condition that gives us a really profound look at how our immune system walks that tightrope between protecting us and attacking us. We're going to break down the complex genetics, trace the pathophysiology, and map out exactly how this presents in a clinical setting. But first, consider this medical mystery. What if a child repeatedly develops persistent fungal infections in their mouth, followed by sudden, terrifying episodes of low calcium, causing muscle cramping and tetany, and then years later, life-threatening adrenal failure? Okay, let's dive into this, because the wildest part is that these are not separate, unlucky diseases. They are all manifestations of one single, overarching genetic immune disorder. Here's our roadmap for today's explainer. 1. Meet APS1. 2. Inside the thymus. 3. The domino effect. 4. The classic triad. 5. Diagnosis and treatment. And 6. High-yield pearls. Let's solve this puzzle together. Part 1. Meet APS1, a monogenic medical mystery. So, autoimmune polyglandular syndrome type 1, or APS1, is a really rare, genetically inherited condition. It's passed down in an autosomal recessive pattern. You might also hear it called by its acronym, APED, which stands for Autoimmune Polyendocrinopathy Candidiasis Ectodermal Dystrophy. Let's break that down. Autoimmune means the immune system goes rogue and attacks healthy tissues, and polyglandular means multiple hormone-producing organs are taking the hit. The absolute core concept you've got to grasp here, it's a catastrophic failure of immune tolerance. Part 2. Inside the thymus, genetics, and the AIER mutation. To understand how immune tolerance fails so spectacularly, we have to zoom way in, right down to the cellular level. Normally, your body should only react to things that are foreign. This is maintained by immune tolerance, where only non-self-reactive immune cells are allowed to mature. For our T cells, this strict education happens in the thymus. Specifically, thymic medullary epithelial cells express a critical gene known as AIRE, which stands for autoimmune regulator. When T cells are developing, this AIRE gene forces the production of thousands of your body's normal proteins. It essentially serves as a massive final exam to test whether these developing T cells will wrongfully react to your own self-proteins. Now, what's really interesting is the stark contrast between a healthy system and APS1. In a normal thymus, if a T cell reacts to those self-proteins during the exam, it's game over. It undergoes apoptosis or programmed cell death. Alternatively, it turns into a regulatory T cell, which actually goes out and suppresses other rogue cells. But in APS1, there is a genetic mutation in that IRE gene. The final exam is completely canceled. Those epithelial cells literally lose the ability to display the body's self-proteins. Without this test, self-reactive T cells blindly survive, graduate, and escape right into the bloodstream. Plus, those protective regulatory T cells aren't produced normally anymore. The body loses not just one, but two primary mechanisms for preventing autoimmunity. Part 3. The domino effect. Tracing the pathophysiology. Let's trace how this builds across the entire physiological cascade. Step 1, the AIR gene mutation we just talked about. That directly triggers Step 2, a profound loss of immune tolerance. Because of that loss, we hit Step 3, the unchecked escape of autoreactive T cells, which start turning out autoantibodies that actively target normal tissues. And that culminates in Step 4, autoimmune endocrine gland destruction. For reasons we're still figuring out, these rogue T cells have a massive affinity for targeting specific glandular tissues, most notably the parathyroid glands and the adrenal glands. Part 4, the classic triad, the clinical hallmark of APS1. And this brilliantly illustrates the clinical hallmark of APS1, tying right back to those puzzling symptoms from our opening hook. It's the classic triad. First up is chronic mucocutaneous candidiasis. This is almost always your earliest clue, usually popping up in childhood. We're talking persistent candida yeast infections on the skin, nails, and mucous membranes like the mouth and esophagus. Second is hypoparathyroidism. When the parathyroid glands are attacked, blood calcium plummets and phosphorus spikes. That hypocalcemia is exactly what causes the severe muscle cramping, tetany, and even seizures. Third is primary adrenal insufficiency, also known as Addison's disease. The destruction of the adrenal glands wipes out critical cortisol and aldosterone levels. Losing those hormones is incredibly dangerous, causing fatigue, hyperpigmentation, hypotension, and potentially life-threatening adrenal crises. While the triad is the classic signature, APS1 is heavily multisystemic. Patients often suffer from ectodermal dystrophy, meaning abnormalities in tissues derived from the ectoderm. Think skin conditions like vitiligo causing areas of hypopigmentation,
alopecia causing bald spots due to hair follicle destruction, or even reduced dental enamel and nail dystrophy. But the immune system doesn't stop there. It can trigger severe inflammation in non-endocrine organs too, like the liver, intestines, lungs, kidneys, and spleen. And over time, other endocrine organs can fail, leading to conditions like type 1 diabetes, hypothyroidism, or gonadal failure.
Part 5. Diagnosis and Treatment. Managing the multi-system failure. So, how do healthcare providers actually identify this complex, evolving web of symptoms? The magic number here is 2. I really want you to remember this. Recognizing the clinical pattern early is absolutely vital, and a clinical diagnosis of APS1 relies on having at least 2 of the 3 classic triad manifestations. If you see a patient with chronic candidiasis who suddenly develops hypoparathyroidism, the alarm bells for APS1 should absolutely be ringing.
To back up those clinical signs, we have some powerful diagnostic tools. We can run DNA testing to hunt directly for mutations in the AIR gene. We could also check labs for specific autoantibodies directed toward interferons, which are a massive red flag since they're highly common in these patients. And finally, standard blood tests will physically confirm the organ damage, showing low calcium, low parathyroid hormone, and low cortisol. When it comes to treatment, the tough reality is that there's no cure for the genetic defect itself. The entire focus shifts to a supportive management plan tailored to the patient. Step 1 is endocrine replacement therapy, using calcium and vitamin D for the hypoparathyroidism and hydrocortisone for the Addison's disease. Step 2 is targeted antifungal therapy, using topical or systemic meds to manage that chronic candidiasis. Step 3 involves immunosuppressive medications, which are incredibly important when there's dangerous non-endocrine organ damage, like liver or lung inflammation. And step 4 is absolutely crucial, regular monitoring. Because this disease is progressive, you have to continuously screen for new endocrine failures before they turn into a crisis.
Part 6. High-yield pearls, rapid review equations. So the crucial point is this one simple, elegant equation that summarizes the entire physiological cascade. Everything starts with the AIRE mutation in the thymus. That directly leads to a loss of immune tolerance. That loss unleashes unchecked autoimmunity, which ultimately results in multiple endocrine failure. Keep this flow in mind, and the logic of the disease will always make perfect sense to you.
All right, let's rapid fire the top exam pearls. The inheritance pattern, autosomal recessive. The core defect, a mutation in the AIRE gene in the thymus. The earliest clinical feature you'll usually spot, chronic mucocutaneous candidiasis in childhood. The defining classic triad, candidiasis, hypoparathyroidism, and Addison's disease. And the most important frequently targeted endocrine organs, for sure, the parathyroid and adrenal glands.
APS1 is just a stark reminder of the incredible, silent work our bodies do every single day to differentiate friend from foe. And it leaves us with a really compelling question. If a single genetic mutation in the AIRE gene can dismantle our immune tolerance so profoundly, what other secrets is the thymus hiding about the fundamental origins of autoimmunity? Keep questioning, keep learning, and thanks for joining me for this explainer on MedNexus. Catch you next time.